Good morning, everyone. Before I begin, I would like to congratulate Vikas and Anand for putting up such a fantastic scientific agenda for this meeting. You feel very proud when your students do well, and I'm certainly very proud of the two of them today for putting such an excellent program. So Vikas wanted me to speak on mucositis in general, but being a transplant physician, I thought of tweaking it a bit and talk about mucositis in transplant setting. So as we all know, mucositis is an inflammation of the whole GI tract, not only of the oral cavity. And depending on the intensity of the chemotherapy or radiotherapy, the incidence of severe mucositis could be anything between 70 to 80%. As far as transplant is concerned, when you give full intensity conditioning regimens with radiotherapy and chemotherapy, then nearly all patients develop at least grade 3 oral mucositis. With mucositis come major problems. There is odynophagia, dysphagia, increased risk of infections, which probably is the most important. And then there is decrease in nutrition. And as Chetan just mentioned, some of those things are applicable even for severe mucositis, that how you need to feed these patients when they can't eat at all. And of course, there is increase in the hospital stay, and that also increases in the cost of the whole treatment. There has been a significant advancement in the pathogenesis of mucositis. And why I will talk a bit about that is because the recent interventions are more mechanistic based, depending upon the pathogenesis, compared to the previous interventions where it was more broad according to what physicians felt could be used to ameliorate the inflammation. So when we look at the recent mechanistic signals which are probably involved in mucositis, one could divide them into 5 phases. So when you have a DNA damage because of chemotherapy or radiotherapy, there is an increased production of reactive oxygen species. This leads to increased transcription factor expression, which leads to increase in inflammatory cytokines. Then there is further amplification of those signals, which then leads to ulceration. And then after a few days, there is the healing. Now, phase 1, 2, and 3 is subclinical. You really don't see any evidence of clinical mucositis in a patient. It's only when it comes to between phase 3 and phase 4 that you see the clinical implication of that. And that is the reason that why we need to act before it becomes phase 4. Now, this is an elegant cartoon which again comes from a seminal review way back in 2004, where it very nicely depicts what happens to the epithelium when it gets injured by radiation or chemotherapy. Now you can see that there are lots of inflammatory cells which come in, and with the microorganisms which are always present in the GI tract, which then increases the risk of infection. One important component is the damage to the endothelial cells because of the radiation and chemotherapy, and that probably plays an important role in the pathogenesis of mucositis. Finally, there are anti-inflammatory cytokines which come in with cells such as mesenchymal cells and fibroblasts, which then leads to the healing of the mucosa. So in a simplistic way, you have chemotherapy or radiation. The most important transcription factor is the NF-kappa B. Now when that gets amplified, then there is an increase in the various inflammatory cytokines through various signaling pathways, and you can see there are 3 or 4 in this cartoon. And that then further amplifies and then leads to the inflammation. So first you have inflammatory cytokines causing the mucositis. Then there are the cells, inflammatory cells, which come in and further amplify. And then you have the anti-inflammatory cytokines, which predominantly are interleukin 10, interleukin 4, and 11, and through its signaling pathways, which then leads to the healing. When we talk about mechanistically based interventions, there are quite a few which have been developed keeping in mind the recent advancement in pathogenesis, of which the ones which I've highlighted in red are the ones which we've used in transplant. Amifostine is an old drug. Many of us in the audience would know. That was used for mucositis way back, but it's no longer a promising agent used because of the side effects of amifostine. Keratinocyte growth factor is something which I will delve in a bit more, and that is because it is probably one of the most important agents to decrease the incidence of mucositis. And I will then talk some about curcumin, which is what we have done in our institute to see if it helps in mucositis. Standard of care for mucositis remains what most of us would know: the good oral hygiene, keeping your mouth wet, and making sure that you're not using dental floss. And those remain standard even in this day and age. Now, the first is the Cochrane review, which came in 2011. Now, there are more than 130 randomized studies which have been published till 2011, not only for transplant, but this is a mixed bag of chemotherapy for non-transplant patients, radiation, and transplant patients. Of these 130 randomized studies, 10 interventions which were sort of found to be better than placebo were the aloe vera, use of aloe vera, amifostine, cryotherapy, GCSF, honey, palifermin, laser therapy. Now, we'll have to look at what exactly it means to use any of these agents for mucositis. So for the amifostine, which was actually used first to prevent the toxicity of cisplatin, it was also found that it can decrease the mucositis because of its scavenging effect on the free radicals. Now, this is one of those studies which was published way back in 2005, a small randomized study in which 910 milligram per meter square of amifostine was used half an hour before melphalan was given to the patient of multiple myeloma for transplant. Now, when you look at the incidence of grade 3, grade 4 mucositis, there was a clear-cut difference that the amifostine did better than placebo. Now, after this, there were a few more studies which came, but the biggest drawback of amifostine was the hypotension which developed when you gave amifostine. So this certainly is no longer a very sought-after agent for mucositis. And when we used it, when I was a DM student, when we used it in AIMS, it wasn't very easy to use it, and of course, it was expensive. The second intervention, which deserves mention and credit, is the use of cryotherapy, not only in transplant setting, but even in non-transplant setting. So this is a small randomized study of 40 patients, again, myeloma patients with cryotherapy being used. That means crushed ice being kept in the mouth at least half an hour before the melphalan infusion is given, and then continue for another 6 hours. Now, this is based on a very elegant hypothesis that if you decrease the blood supply to the oral cavity, then the incidence of mucositis would be less because the drug delivery to that area would be less. Now, if you look at this graph, you can see that the mucositis score and the duration of mucositis was much less in those who received cryotherapy rather than placebo. Now, there has been a meta-analysis which was published in 2016 of patients who received oral cryotherapy for prevention of oral mucositis. And you can see that of the 14 randomized study, which again was heterogeneous, it had patients who received chemotherapy as well as patients who underwent transplant. There is, the conclusion was that it does help in patients who receive 5-FU-based chemotherapy and also in melphalan-based chemotherapy for transplant. Again, if you go into the paper itself, you will see that the numbers are small. Even then, if you pool the data from all the studies, there seems to be some conclusion that cryotherapy helps in oral mucositis. This is a very simple, cheap intervention. It may be difficult for the patient for keeping crushed ice for a long time. However, if the patients agree to it, I think it's one of the most economical way of treating mucositis. Secondly, laser, helium neon laser has been explored in mucositis, and this is not new. It's been there for more than 15 years. In that, it was tried in transplant and even in non-transplant patients. And this is one study which even the surgeons do in their trials, that the patient him or herself is the control as well as the experimental arm. So this was a small study of 20 patients in which the one cheek of the patient received the laser, helium neon laser, and the other cheek was kept as control for these patients who underwent transplant with busulfan-containing regimen. And what these researchers saw was there was a significant reduction in oral mucositis and pain in the cheek which received the helium neon laser. Again, it is something which is non-toxic, but then of course it requires infrastructure and equipment, and it may not be easily available in every part of the world. There has been a systematic review on the patients who have received the helium neon laser therapy, and this is the pediatric population, the meta-analysis which was published in 2017. One can see that it was found to be effective both in decreasing the incidence of mucositis and also for the treatment of mucositis. Again, if you look at the numbers are very small. These randomized studies have been in patients of at least 20 to 100 patients randomized in each arm. So it's not clear whether one can extrapolate the conclusions of each study. And if you look at the forest plot, most of them have been the treatment arm, the experimental arm was actually not better than the treatment arm, but when you pool the analysis data, then there was some significant difference. The next is keratinocyte growth factor, and this has been there for more than 8 to 10 years. And when it came in the setting of transplant patients, it was supposedly the wonder drug. But as most drugs fail in many disciplines of medicine, so palifermin, when it came, it was probably meant to be the best drug to decrease mucositis, but actually it didn't happen. And the reason is that it is a keratinocyte growth factor. It is a mitogen for the epithelial cells to regenerate in the gut, but it is specific for signals which come through radiation damage and probably not through chemotherapy, at least in the high-dose therapy of transplant setting. So this was the seminal study, which was a very large study of 212 patients compared to all the other studies where the numbers were 30 to 60, where they randomized patients who underwent transplant with a conditioning regimen of etoposide, cyclophosphamide, and TBI, and they found that there was a marked reduction in the incidence of grade 3 and grade 4 mucositis in those who received palifermin before the conditioning regimen. You can see that the placebo arm had a large proportion of grade 4 and grade 3 oral mucositis, while the experimental arm had significantly less mucositis. This led to the stage of using it even for high-dose chemotherapy without TBI. And this is where it failed. When it was used in only chemotherapy-based conditioning regimens, and this is a randomized study, it failed to show any difference of using palifermin with or without melphalan or beam chemotherapy. Again, in allogenic transplant, it was used, and this is a retrospective analysis, in which it showed that if you used a TBI-based regimen, there was a difference in the mucositis if you used palifermin, but if you used only a chemotherapy regimen, it did not show a significant difference. And that is what you see in this table, that the TPN requirement and the PCA and the length of hospital stay was less in patients who received palifermin in the TBI-based regimen rather than in only chemo-based regimen. Again, there's a meta-analysis to look at the role of palifermin in not only transplant, but even in non-transplant setting. Not only palifermin, but also other cytokines. And the conclusion of this meta-analysis is that it is beneficial for those receiving radiotherapy with cisplatin or 5-FU, for patients who undergo radiation with chemotherapy in head and neck setting. It probably had some benefit in chemotherapy in solid tumors and heme malignancy in the non-transplant setting. However, for what it was actually meant to be used in the transplant setting, the benefit was probably only in TBI-based regimen and not in chemotherapy-based regimen. No other cytokines such as GMCS, GCSF, erythropoietin were found to be of benefit in this large meta-analysis. Now, Deviation from transplant, there is also honey, which has been there for years, and it's again something which is very cheap and easily available across the world. What is the evidence that honey may ameliorate mucositis? There is a meta-analysis of using honey, topical honey, in various settings, predominantly in radiation treatment and chemotherapy, or combination of chemo and radiation. And when you look at the randomized trials which show its benefit both in the prophylactic and therapeutic setting, there seems to be a benefit of using honey in this setting. As far as transplant is considered, in that setting, we really don't have much data of use of honey, but certainly this again tells us so some of these simple measures may be beneficial. Curcumin is something which has been available in our country for more than hundreds of years, and it is something which we all use in our families as an anti-inflammatory for various conditions. However, when you come to the mechanistic way in which curcumin acts, it is probably through the inhibition of the NF-kappa beta. If you look at the targets of curcumin, they are myriads. There isn't any signaling pathway where curcumin does not inhibit or activate according to its property. But when it comes to diseases in which curcumins are used, again, there are plenty of them. It's not only in malignancies, but there are many of these inflammatory disorders in which curcumin is used. So obviously, this was something of interest to us because we felt that it is cheap, it is easily available, and can we do a study to see whether curcumin decreases the incidence of mucositis in patients undergoing transplant. So this was a study which was planned way back in 2008, 2009. We did a pharmacokinetic pharmacodynamic study because we wanted to first find out the mechanistic pathway by which curcumin may probably be leading to decrease in mucositis, if it actually does lead to a decrease in mucositis. So what we did is we wanted to look at the levels of various cytokines, and there are 8 cytokines which we looked at in the saliva and serum at various time points after giving conditioning chemotherapy for myeloma patients with melphalan. We also measured the curcumin levels at different time points because curcumin level measurement is not easy, and we wanted to prove, if it could be proven, that there is curcumin level in the blood, and probably that is how it may be decreasing the cytokines in the body. The secondary objective was to look at the grade 3, grade 4 oral mucositis, diarrhea, and other toxicities. So we did 2 phases of it. It's not a randomized study. The first phase was 10 patients who did not receive curcumin. And the second phase was the treatment phase in which the next 30 patients received curcumin lozenges, and these were 4-gram lozenges, 4 tablets in the morning and 4 in the evening. Why did we use lozenges? And we got it specifically prepared for this study is because when you have grade 3, grade 4 mucositis, all of us know that you can't swallow capsules and tablets. So these lozenges will melt in the mouth, and that again will be probably better as far as the compliance of patients will be considered. All patients receive melphalan 200 milligram per meter square as the conditioning regimen for multiple myeloma transplant. Now these are the time points in which we measured the cytokines for this study. So the first 10 who did not receive curcumin, we measured the cytokine 1 hour before the melphalan and then at different time points till day 28. And the group which received curcumin, we measured the cytokines from the time we started curcumin and at different time points. And these are both serum and saliva cytokines. We also measured the curcumin at different time points after starting curcumin till day 28. So it was actually a lot of translational parameters to look at the cytokines and the curcumin levels. Now what we found, the baseline characteristics were same. I will straight come to the toxicity, that the incidence of grade 3, grade 4 diarrhea was lesser in the curcumin group. The TPN and the grade 3, grade 4 nausea and vomiting was less. For mucositis, surprisingly, we did find a difference between the curcumin and the non-curcumin arm, but it wasn't statistically significant. When we looked at various cytokines, we did see that most of the inflammatory cytokines were lower in those who received curcumin, both in serum and saliva, and was higher in the placebo, that was the non-curcumin group. And we could also measure the curcumin levels in the patients who received curcumin. So this conclusion from this study was that curcumin does lead to a decrease in the inflammatory cytokines, both in serum and saliva, and probably does lead to a decrease in mucositis. This has led to what we are doing right now, a phase 3 randomized study of curcumin in patients with autologous transplant setting. And the results obviously will take few years. I will just end with another study which we are doing, in which we are using resveratrol copper in mucositis. And this comes from Dr. Mitra's lab, where the hypothesis is that the oral resveratrol will inhibit the levels of toxic inflammatory cytokines involved in transplant. And here again, it is based on the hypothesis that chemotherapy releases chromatin. That leads to the damage to the tissues. And if you degrade the chromatin with resveratrol copper, it will lead to benefit. And this is what we are doing. We have got 5 phases, 5 groups of patients with various doses of resveratrol copper. And the initial 10 patients show some promise that those who receive resveratrol copper have less mucositis. So I would conclude that there are myriad of agents over the last 30 years used in mucositis. Some are very economically inexpensive to be used in our country, like cryotherapy, honey, curcumin, maybe resveratrol copper. Some are terribly expensive, like palifermin. Some are needs infrastructure, like helium. But I think we need larger, well-designed studies to find out which of these agents will probably be the standard of care. Thank you for your attention.